Chapter 6 talks about bacterial infections acquired through the skin, mucosa, and bloodstream from human and endogenous sources. Folliculitis, furnicles, which are also known as boils, and carbuncles. Most furnicles or boils and carbuncles are caused by Staphylococcus aureus, as are many cases of folliculitis. The only difference between the three are that carbuncles end up being the most severe, so the basic difference is the degree of severity. Folliculitis is the inflammation of a hair follicle, and we've probably all had that. A lot of times you see that more on men in the beard area, and it's basically where a hair will get trapped and doesn't break through the skin for whatever reason, and it causes almost like a little abscess underneath the skin. Staph aureus are pyogenic bacteria, meaning they produce pus. Very common in children, usually associated with poor personal hygiene, and also in crowded places. So a lot of times you'll see outbreaks in schools, daycare centers, institutions, and it tends to be that some people seem to be more susceptible to the infection than other people. And generally it has to do with the amount of staph that is living on that individual's skin. Transmission, the reservoir is humans, and Staph aureus is usually present in the nostrils. Over 60% of the population actually carries Staph aureus, which we said it's very common on people. Usually the spread is from person to person, or if someone is a carrier, usually that individual that has Staph aureus present in their nostrils is going to be a carrier. It enters the system through a break in the skin, and if someone has one on their eye, it's usually called a stye, which can be very painful. When someone has MRSA, which is the methicillin-resistant Staph aureus, it's resistant to methicillin, they do a bacterial ointment they have to use in their nose, as well as the other treatment, to try and reduce that bacterial count. And generally, someone going into the hospital with suspected MRSA, they usually swab their nose to see if the culture is present in their nose. If it is, a lot of times that individual is isolated because of the fact that they can spread through, obviously through breathing. And they did a study a while back. They swabbed a group of people's nose that came in through the emergency room, not for MRSA, but just in general, and were admitted to the hospital. They swabbed their nose originally, and then they swabbed their nose before they left to see what the incidence was of patients coming in without staph and leaving with staph, because we know staph runs rampant in the hospitals. One hair follicle being infected is folliculitis. Multiple create a boil, which is hard, painful. It's a nodule commonly on the neck, face, armpits, and buttocks. It will rupture, discharging pus. The carbuncle is marked by an extremely painful deep abscess that drains through multiple openings. So usually it's not just that one center that you see with folliculitis or with a boil. It's multiple areas where it drains from. Treatment with folliculitis is pretty much just cleaning the wound, keeping the wound clean, and using an antibiotic ointment. Boils and carbuncles, clean the wound, use the antibiotic ointment. Generally, it's a prescription ointment. Warm compresses will help to soothe it, and it also helps to draw the pus to the surface. In some cases, antibiotic orally is used, as well as surgical drainage or incision and drainage of the carbuncle. Prevention, good personal hygiene, so that's always washing your hands, washing your face. And the other thing is not to squeeze the boil, because if the walls of that boil break, then that bacteria can enter the bloodstream, causing like a septicemia or bacteriemia in the systemically in the patient. So these lesions on the back of this individual's neck, to me, I think they look like carbuncles. If you look at them closely, you can kind of see where there's several pustules within one. So I would have to say those would go from a boil to a carbuncle. That would be my take on it. You can see how painful that those look. Next, the book talks about impetigo, which is very common in newborn and children. It may be caused by the Staph aureus bacteria as well as Streptococcus pyogenes. Poor skin hygiene in skin conditions such as abrasions or draining wounds is typical. It's very common, like it said, in newborns, and usually with a newborn, they pick it up at the hospital. The individual, like I said, hospital staff runs rampant, and usually the child will pick it up there. My son, in particular, had uh, impetigo when he was an infant. When he came home from the hospital, within a few days, his bottom all broke out underneath the diaper, and it was diagnosed at that time as a hospital staph infection. The incubation is 4 to 10 days, and it is communicable while it's draining. The transmission can be either direct or indirect. So you can cut yourself with something that has the bacteria on it, and you're probably going to get impetigo. It starts as a small red spot that develops into a vesicle and then becomes pustular. The pustule ruptures and becomes crusty, and usually you see it a lot of times on the face. Treatment is remove the crusts, clean the wounds, and antibiotic ointment. It is highly contagious. When my son went to college, he got it on his face from his razor. He set his razor blades down on the sink, and when I saw him, he told me he thought he had acne, which he never had any acne or pimples on his skin. And as soon as I saw it, I knew it was impetigo because of the crusts that were on it. So never ever share personal hygiene. Um, Razors, brushes, combs, nothing. And that's another thing. Don't ever put your razor blade down. Always make sure the razor blade is up, because if you nick yourself, which I'm sure he did, he had to shave every day because he was at a military academy, so he shaved every day, and I'm sure he nicked himself, and that's how he ended up with the impetigo. So this is an infant with impetigo. You can kind of see the yellow crusty lesions on his face. And once again, all this is highly contagious because all of it is filled with the pus that has the bacteria in it. And here's one on the chin area, probably from the same situation, although my son's wasn't, nearly that bad. But you can see how crusty, once these blisters break, they crust. And all that needs to be washed off, and then ointment on it several times a day. Next is osteomyelitis. And this is an infection of the bone and the bone marrow, which can be a chronic infection or an acute infection. It's more common in children than adults. Common sites are in the lower end of the femur and the upper end of the tibia, humerus, and radius. In adults, you'll see the infection in the bones of the pelvis or the vertebrae. Acute osteomyelitis, with prompt treatment, the outcome is good. If you have chronic, it's poor, because for whatever reason, the actual bacteria is not reacting to the antibiotic. This is what I was telling you when I had osteomyelitis in my elbow from the injections. Um, that it was getting to the point where we were concerned if I was going to end up losing my arm, because it was going from an acute stage to a chronic stage where it was not resolving with any of the antibiotics. And pretty much the only way to get rid of it is to remove the bone that's infected. And so that's why I was so concerned I was going to end up losing my arm from the elbow down. But as it turned out, I was fortunate enough that I did respond to the rifampin. So um, I did have to have surgery to go in and remove, to scrape the bone, do an incision and drainage of the bone, and remove any of the dead necrotic tissue in order to allow the healing to begin. And they left that open so that I could have air, because remember, these bacteria like that warm, dark, moist environment. This is not an infection that's on the outside of your body. It is an internal infection, usually caused by Staph aureus. You can get osteomyelitis from squeezing a boil or a carbuncle if it's close enough to the bone, and it moves if the wall of that boil breaks. That infection can go directly to the bone. The other person who is at risk for osteomyelitis are individuals that have been in car accidents or had trauma. And so remember, if you even take, for instance, a motorcycle rider if they fall off their bike and break their leg. But remember, they've probably got a lot of dirt and gravel that have been pushed into that wound as well. That is a nice environment for osteomyelitis as well. Generally speaking, you can see osteomyelitis as well with dental extractions. If any instruments, or if the patient happens to have bad oral hygiene or periodontal disease where the infection or the bacteria is present in their mouth, you can see it in a surgical site within the mouth as well. Symptoms: sudden pain, heat, tenderness, and restriction of movement over the bone, which those are all exactly what happened with my elbow. The treatment is 4 to 8 weeks of antibiotic therapy. Surgical debridement and drainage are needed for healing, which I just said I had all of those. Actually was on the antibiotic much longer than 8 weeks, but that's the recommended treatment, and that's what ended up happening with me as well. I had an orthopedic surgeon that did the surgery on the bone for me. Prevention: do not squeeze boils or other pus-containing lesions, because it's possible to get that infection into your body. And you should practice sterile procedures when changing any dressings, because of the fact that that drainage is contagious. So generally speaking, you should have a separate bag, put all the dressings, anything you use to clean the wound with in that bag, tie it shut before disposing of it. Next, the book talks about meningitis. The meninges are membranes that surround the brain and the spinal cord or central nervous system. Meningitis occurs when an inflammation in those membranes occur. There's 2 organisms that are responsible for most cases: the Neisseria meningitis and the Strep pneumoniae is the other organism. Transmission depends most often. I'm sorry, I'm reading this and I see that I have respiratory spelled wrong here. Doesn't look like spell check was working, huh? Depends most often. It's transmitted by direct contact with respiratory secretions from an infected person. Symptoms: fever, intense headache, nausea, and vomiting. Stiff neck is a big symptom. Oftentimes there's a rash. As the disease progresses, the individual can start to have twitching, seizures, or even a coma. The treatment for it is going to be an IV antibiotic for 2 weeks, followed by oral antibiotics. Generally, ampicillin is the drug of choice. However, there are some of the bacteria that are resistant to the ampicillin, and that at that point then they use a cephalosporin. But usually with one or the other or a combination, it's very treatable. Prevention of meningitis: a vaccine is available for H. influenza type B and is recommended for children under 15 months of age. Control, isolate the patient for 24 hours after treatment, begins with antibiotics. At times, they will use rifampin, which is a drug that we've talked a lot about in reference to my elbow and tuberculosis. Rifampin can be used prophylactically on individuals that have possibly been exposed to someone that has meningitis, and they want to treat the patient so they don't come down with it. It would be rifampin. Endocarditis, or it's also known as endobacterial carditis, is an inflammation of the endocardium of the heart, which is the inner lining of the heart. Usually affects the valves. It's usually caused by strep or staphylococcal, and how the individual obtains the disease is when bacteria enters the bloodstream and enters the heart. Drug addicts, dental and surgical procedures put patients at a higher risk. Before antibiotics, 95% of individuals would die because, obviously it's a bacterial infection in your heart. Now, about 65 to 80% of the patients will recover. Individuals, I'm sure you remember that if you had mitral valve prolapse or you had a heart murmur, they would always pre-medicate you for any surgical procedures, any dental procedures, even cleanings, they called it, anything that was dirty, even colonoscopies. They've gotten away from that now because of the risk of becoming immune to a lot of the antibiotics, and also the risk of the individual taking antibiotics and having an allergic reaction to them. So they kind of said that the risk of taking antibiotics, having a reaction, or becoming immune to them is greater than the risk of obtaining endobacterial carditis. Generally speaking, somebody usually has something wrong with one of the valves in their heart. Like I said, a lot of patients with mitral valve prolapse, even then they changed the protocol that if you had regurgitation of the valve, blood regurgitation, then you needed a prophylactic antibiotic before any surgical or dental procedures. Now they have changed the protocol again, that the only time you need to have prophylactic antibiotic is if you've had a valve replacement, a valve repair, or a past history of endocarditis. So that's the American Heart Association's recommendations for pre-medication on dental and surgical procedures. Treatment is high doses of antibiotics given IV and continued as long as 6 weeks. If the valve is damaged from the bacteria, then surgical repair or replacement is needed. There is no control for it, and the prevention we just talked about are antibiotics prophylactically for the recommended group, valve repair, replacement, or the history of endocarditis should have antibiotic prophylactically before they have any surgical or dirty procedures completed. Syphilis is a sexually transmitted disease. It's a spirochete, Triponia pallidum, enters the body through mucous membranes. There are 3 stages to syphilis. primary, secondary, latent, late, or tertiary. Syphilis is a very destructive organism that is gone on all through time. There have been thousands and thousands and thousands of people that have died or been maimed by syphilis. The incubation period is 10 days to 3 months. It's usually 3 weeks. The disease is communicable in all 3 stages, and it can be transmitted to the fetus in the womb. Not traveling through the birth canal, but in the womb. Transmission is direct contact with body fluids containing the organism during sexual or other intimate contact. It can be transmitted through blood transfusions from a victim in the early stages of the disease, and the organism can only exist in moist body fluid. So when you see it, the top, when it talks about direct, it isn't direct and indirect, it's direct contact. So once your clothes are washed and dried, you no longer, have that organism on them. The symptoms are, the first sign is a painless sore, or also called chancre, at the point at which the organism invaded the body. So naturally you're going to see a lot of the chancres are going to be in the genital area. Because it's painless, it may be in the rectum or on the cervix, and because it disappears in 4 to 6 weeks, it generally goes untreated and undiagnosed. This is the primary stage. So if you had a lesion on your cervix from intercourse, you would never know you had it there. So here's a picture of primary syphilis, the chancre. It usually appears 10 to 90 days. Single, painless. It's a clean base lesion with rolled edges. Here on the edge of this man's penis, you can see the rolled edges of the lesion. And in the other picture, the 2 lesions in the vaginal area. Here's a picture of a chancre on the tongue. So although you can see it and it has rolled borders and it looks like it would be painful, it is not painful. The patient very rarely, I'm looking at this and I'm looking at not just the lesion in the very middle, but if you look on the outside, the rolled borders of that lesion. Syphilis in the secondary stage, which may not develop within, or may develop within a few days to 8 weeks, most often includes a rash, swollen lymph nodes, headache, aches and pains of the bones, loss of appetite, fever, fatigue, hair may fall out in clumps, and meningitis may occur. For many, there will be no more symptoms, but about 30% will go into the latent stage. The first symptom in the latent stage occurs in 1 to 25 years after the patient is infected. The basic lesion of this stage is called a guma. So here's a picture of the rash that you'll see in the secondary stage. Generally speaking, if you had something that looked like this, you'd be going to the doctor saying, you know, what's wrong with me? But remember, many, many years ago when this was going on, that they didn't have doctors readily available, and they carried this disease, you know, for years and years and years. And men would go to war, they would come home, and they would bring this disease home to their wives, and it was just a very vicious cycle. And there's also, I believe I put it in our readings, a video from the United States testing uh, the black males in Tuskegee, Georgia, with syphilis, doing a study on them, and it's quite horrifying to think that the United States would do that to their citizens. But I believe I have that in our module for you to review as well. Here is the secondary rash on someone's hand. And here is the guma, which is the basic lesion of the third stage, or the tertiary stage of syphilis. So you can see how this basically maims people. Treatment can be cured with penicillin in all three stages. However, the damage that has come from the disease will never be reversed. So remember, this is a disease that also will affect the brain in the third stage. So when they, you know, it's kind of referred to as a disease that you'll go crazy from, but it's really because it has affected the brain as well. It's infiltrated the brain. Prevention is monogamous relationships. Condoms do offer some protection, but not much protection. So basically, it's monogamous relationships, and you know, not being flamboyant with your sexual activity. It is necessary by the health department that if anybody is diagnosed with syphilis, that it has to be reported to the health department, as well as everybody that the individual has been in sexual contact with. And then all those individuals have to be tracked down and tested, and everybody that they have been with and they have been with sexually have to be tracked down. So you can see what a long chain reaction that makes from, you know, just one case of syphilis. Next is gonorrhea, caused by gonococcus, Neisseria gonorrhea. Second most common transmitted, sexually transmitted disease to chlamydia, which we're going to talk about next, which will be our last sexually transmitted disease. Incubation period for gonorrhea is 2 to 7 days. Transmission, again, is contact with body fluid through individuals that are sexually active. Also, gonorrhea has been noted in children above 1 year of age, is also associated with sexual molestation. Symptoms: in 80% of all women, no symptoms are really noted until the disease infects the fallopian tubes. If there are symptoms, they're very mild. It's usually a vaginal discharge or burning sensation on urination. If the disease goes untreated for women, other symptoms occur depending on the site of the infection: frequent urination, itching, pain of the vulva, redness, swelling, and discharge from the vagina. For men, a purulent urethral discharge, also may be redness and swelling in the penis area, or they can have no symptoms at all associated with it. Babies that are born in a hospital require silver nitrate drops at birth to prevent the severe eye infection that they can get if the mother has gonorrhea when she delivers. So that's pretty standard. It was very, very prominent back in the 60s and 70s. Untreated can lead to inflammation of the prostate and testes, affecting fertility in the man. In women, gonorrhea can lead to PID, which is pelvic inflammatory disease. It can also lead to ectopic pregnancies and infertilities. Treatment is penicillin or PCN, VK, or ampicillin. There are 3 strains that are resistant to antibiotics. The damage that gonorrhea has created before it is treated is not reversible. The prevention is the same as syphilis, and the control is the same as syphilis. Chlamydia, genital infections. Chlamydia is the leading sexually transmitted disease in the United States. It acts more like a virus, but it still is classified as a bacteria. It does have to have a host, does have to have somewhere to live. Chlamydia trachomatis is its technical name. Incubation is 7 to 14 days. Everyone is susceptible. Transmission is through sexual contact, at birth through the birth canal, causing severe eye infections and pneumonia in the newborn. I have also heard or read studies where they believe chlamydia can be transferred from a towel. So if someone within a time frame, because remember it does have to have the host to live, someone uses a towel and dries themselves off in the genital area and the next person uses it, I have heard that chlamydia could be spread that way. Both men and women can be asymptomatic and have no symptoms at all. When there are symptoms, it's once again very vague. There may be discharge from the vagina or the penis, swelling of the testes for men, and painful urination for females, which, as we know, we just read that with gonorrhea. If the disease is untreated, it can cause infertility for men and women. And treatment, antibiotics, prevention, same as gonorrhea and syphilis, control, testing of partners and other contacts. So if an individual has these symptoms, they really should be tested for all STDs because they do kind of mimic each other.